in 2016, Steinerhouse et al. Published an article looking at outcomes for individuals with autism. And they basically found that 47% of individuals with outcome have poor to very poor outcomes. Well, 2016 wasn't too long ago. I mean, yes, it's 10 years ago. Things have drastically changed, I hope. And so let's say that the research was actually done in 2014, took 2 years to get published. Not that long ago. And hopefully those numbers have changed a little bit. But what that number speaks to me about is that the treatment models that we had been implementing are missing something because we aren't getting the outcomes that we really want to see. And I would actually, just given my training and what we do at Jumpstart as part of the challenges of addressing and building systems that really ensure we're addressing the whole child and kind of their specific needs, is that I think we're missing some of the medical pieces. That we know that 80% of individuals have a co-occurring behavioral health diagnosis. We know that 60% of individuals on the autism spectrum have 3 co-occurring, can minimally be diagnosed with 3 co-occurring behavioral health diagnoses. And then you start looking at medical, right? And I don't know the exact numbers on the medical, seizures, I think, 12% of our population. GI, and unfortunately, I just don't have those numbers right on top of my head, but it's pretty significant. And if you're providing ABA services to a neurodiverse population, I guarantee there's some pretty significant medical complications that are impacting your treatment outcomes. A lot of our young BCBAs don't have the experience to identify, they don't have the training nor experience to understand when a medical issue is impacting learning, which creates, in my opinion, and now this is again my training, creates a massive problem in that from a psychologist or even a BCBA perspective, if you're providing behavioral interventions for a known medical condition, that could be considered practicing out of work scope of work, right? Right. So ethical problem, minimally. Yeah. Well, but if you're treating and billing insurance for behavioral health services that will not make a difference to a medical condition, then that could, some insurances could consider that fraud.
Right.
It's a major issue. And unfortunately, the field has done nothing about it. And by the field, I don't mean, the board or anything like that. I mean, the field of behavior analysis, the profession of it. And how do we support a lot of young BCBAs or even businesses support BCBAs and to support the medical needs?
One of the things I talk about a lot, and that was important to me and how I supported my staff when we had our own agency, was like even understanding the human development, and understanding the stages and the progression and what that would look like. And even being able to look at your goals and saying, is this an appropriate goal? I can't tell you how many 100% compliance goals.
It's not reasonable.
The tantruming. The child will tantrum 0 out of 3 occasions across whatever. For a 2-year-old, I'm like, have you met a 2-year-old? Right. Yeah. And that's just looking at your traditional development, norms across the last decade, across the past decades.
Yes.
Not to mention you throwing in like the different medical, and that also brings us to like medical necessity and how well as a field do we really understand medical necessity and what that means. So all of these pieces and bringing them together, which each piece alone is a huge thing.
Yes.
But how do you remedy that? Like, how does a business owner right now who's like, oh shoot, I'm a BCBA. I started this business because I want to do better. I want to provide quality services. I want to fill in those gaps that maybe I didn't have in previous companies that I worked with. I am limited in my knowledge and what I know, but I do want to do better. I know, like, where do we go from here? What do we do?
Well, isn't that a great first step? Is kind of the acknowledgement and the awareness, and it doesn't matter what level you are. There's kind of those oh shit moments where you're like, well, I had no idea that this was a problem. An example of that. So probably, let's say of 2014, 13, 12, I don't know, somewhere in there. I had to do a prior authorization review with a psychiatrist around ABA. Well, they don't know anything about ABA. And they're going off of, they said, okay, so what's the medical necessity for this service? And I'm like, the what? what are you talking about, Matt? And he goes, yeah, you should be able to give me the medical necessity. And I'm like, Dr. So-and-so, I've never heard this term. I've been in the field. I've never heard this. What can you please outline what you mean by medical necessity? And he kind of went down some of the, what are the main symptoms? What medical, concerns do you have? What are the safety issues? And I was able to kind of answer those questions in that moment, but I left that medical review thinking, boy, I bombed that. Luckily we got what we had requested, but I left that meeting thinking, if I don't know this, our entire team doesn't know it. And so I did a deep dive into documentation of medical necessity for our team that we could include, and really showed some of the different levels to indicate, no treatment, focused treatment, or comprehensive treatment that we include in our treatment plans. That way reviewers can see, from ASD symptoms to medical concerns to adaptive behaviors to, self-interest, physical behavior, that it really equates over to the level of treatment that we're recommending. So now you're starting to talk about standardized questionnaires, and none of our staff had training on standardized questionnaires. And I'm kind of like, well, this is the fruit blood of what we talk about and how we communicate to our insurers and diagnoses, right? And yeah, we've got to convert what it is we do to terms and phrases that the insurance companies understand.